So this is going to start off with module 4. So this is going to be the first part to the test, musculoskeletal. All of the following are true regarding osteoporosis, but what? All right, very good. So when we think about this idea of osteoporosis, three of the answers are correct. One of them is not true. So he wants to find out which one is not true. Osteoporosis is definitely associated with low bone density. So when you hear the term porosis, think about a porous bone or a bone that has lots of holes. And what's actually happening here is we are losing bone. Primarily, we're losing what's called spongy bone or what's called trabecular bone. And so because we're losing that bone, that's why we have low bone density. And those bones typically are very fragile and are more likely to have fractures. So for this one, it's not a problem with too much weight-bearing exercises. Typically, the person that develops osteoporosis doesn't do enough weight-bearing exercises. So there's a lack of weight-bearing exercises. You'll usually see that they do have a hunchback. And again, they're very likely to have a pathological fracture, which means that they have a slight fall. Excuse me. They have a slight fall, and then they end up breaking their hip, or they break their leg, or they break their arm. They're also going to be losing a little bit of height as well, because again, you're losing that bone density, you're losing that trabecular bone, it's thinning away, and again, it's also making them a bit shorter. And if you hear the term kyphosis, that means that they have a hunchback. So they're actually going forward. Let me see if I can make myself go forward. So when you see the person that's like this and they're really, really hunched forward like this, that's your hunchback that you're thinking of. Sway back or lordosis is where their back sways in. With kyphosis, they're actually rounding their back. They're hunching their back. And again, we see osteoporosis along with osteopenia, which is the thinning of the bone. Osteoporosis, you're going to see thinning of that spongy bone or that trabecular bone. Okay, so rheumatology is a science that deals with inflammatory or infectious conditions of the joints and other parts of the musculoskeletal system. Is this true or false? So this is going to be true. So if you hear the term rheumato is going to represent muscle, bone, and joint. And then if you ever see the term ology means the study of. So if you go to a rheumatologist, more than likely you have like rheumatoid arthritis, or maybe this is someone that has issues with osteoarthritis, or maybe that's someone that has gout. They go to see a rheumatologist. So it's dealing with the infections or inflammation that someone has in that muscle, bone, and in that joint. Oh, okay, no problem. So I say, I'll have them pop up anyway, and that's going to be the ultimate goal is we want to see all these little pieces. So even if you can't play, just go ahead and listen in. But does that make sense when it comes to rheumatology? Does that make a little more sense?
Yes.
Okay, cool. So on your test, you're going to be asked what rheumatology is. Again, we're studying all those parts of the musculoskeletal system. So we're thinking bone, we're thinking joint, we're thinking muscle, and how it deals with infection and in inflammation. All right, very good. All right, osteopenia. Thinning of trabecular matrix occurs before osteoporosis. Is this true or false? This is going to be true. So if you hear the term or osteo refers to bone, penia means thinning. There's also a term osteomalacia, which means it's going to soften. So sometimes you'll see that there's thinning of bone, And when we think of thinning of bone, we don't think of compact bone necessarily. That's that inner trabeculae or that spongy bone that's thinning. Osteomalacia is the softening of bone. But when we think of osteopenia, this is when we're first pulling that spongy bone. And what's really happening with osteoporosis is you have an increase in what's called osteoclast activity. So osteoclasts help to break down bone so you can release calcium. But now it's overloaded and it's doing it too much. There's nothing to keep it in check. So we have a lot of this thinning of bone, and then it will develop into osteoporosis, which now you have this very porous bone or this kind of very holy bone, instead of having this nice strong bone. And that's what, again, leads to having a weakened, a low bone density. It makes them more likely for fracture. All right, so these are some risk factors of osteoporosis. They include all but one. Which one of these is not osteoporosis or is not a risk factor? Good, it's obesity. So when we think of what are the risk factors, primarily women are going to be affected with osteoporosis, especially postmenopausal women. This has to do with a lack of estrogen. So we talked about osteoclast activity. Estrogen is going to help to slow down osteoclast activity. So it kind of slows down that rate of stealing that calcium from bone. And unfortunately, postmenopausal women don't have high estrogen levels, so it makes them more at risk. Typically, thin-framed women are more at risk for osteoporosis. Also, smokers, if you have a high caffeine diet, alcoholism can do it, smoking. Also, the lack of weight-bearing exercises too. So again, someone that has osteoporosis isn't exercising. They're not putting stress on that bone. So therefore, again, your body thinks, hey, I can steal from here because you're not utilizing it. So the other thing too is they don't typically have a good amount of vitamin D or calcium because again, it's getting pulled from their bone. But the other thing as well, long-term use of steroids can also make it more likely too. So very good. So obesity wouldn't be one. It's typically small-framed women. All right, so we're going to match the best term here. All right, so when we look at these pieces, we said rheumatology is the study of muscle, it's the study of joints, it's the study of bones. And again, it's really in terms of diseases that go with that. If you hear of myosistitis, it's inflammation of the muscle. Hyperuricemia doesn't trigger rheumatoid arthritis, but it triggers gout. It means that you have very high uric acid levels. And typically that's someone that you would see that has gout. They have uric acid deposits. They end up with that funky red big toe. Osteomyelitis is a bone infection. And so it's inflammation of the bone due to infection. Good. All right. Best first assessment for a patient with degenerative joint disease. All right. So for someone that has degenerative joint disease, we'll kind of go back a little bit. DDD is an issue in between the vertebrae. So you have vertebrae in your back and you have joints or what's actually called a disc. It's called the intervertebral disc. And that starts to degenerate. So it can be a couple things that go wrong. It could be through wear and tear on the body. It can be through trauma. Sometimes people have it where they have a herniated disc. Sometimes they'll have a degenerative disc. But what's happening is that disc starts to impinge those spinal nerves. So you'll hear it called compromised spinal nerves or impingement on the spinal nerves. And when you have impingement, now that leads to something called neuropathy, where they have issues in their nerves. So for someone that has it in their cervical vertebrae, they're going to see usually problems down their arm. So a lot of times they'll talk about tingling pain feelings. Sometimes they have issues with gripping right, because now it's a problem in their neck that now all these spinal nerves don't function properly. So sometimes they'll say burning, they'll say tingling, they'll say pain, and it's going down their neck. For someone that has it in their lumbar region, they're going to have problems usually with pain in their butt, and it runs down the back of the leg. And a lot of times they'll have issues with walking, sitting, standing, things like that. So, to start that off, to kind of see if you have degenerative disc disease, the doctor's going to do a physical exam again. He's going to say, how does this feel? Again, do you have issues with gripping? What are some signs and symptoms that you see? With someone that has it in their lower back, they're going to say, okay, how does bending, lifting, twisting feel? And then they're going to do an x-ray. From there, they would do an MRI, but the first things that they'll do are physical exam and x-ray, and then they'll follow with an MRI. And that MRI will actually be the indicative of degenerative disc disease. So far, is this making sense and helping a little bit?
Yes.
All right, awesome. So, and if I'm talking too fast, just let me know and I'll slow down. All right, so what is gout? Yep. So gout is going to be that hyperuricemia. Typically, males are more likely to have gout. It's not saying that females can't, but males typically are more afflicted with it. And usually, what you'll see is that they have these uric acid deposits. Hold up just one moment. Sorry about that. I had something stuck in my throat. Whew, that wasn't good. All right, so typically, what you'll see is they get these uric acid crystals and they deposit in joints. What's most common that you'll see, and again, this is a pretty common thing that happens with gout, especially in males, is they get this super flaming red big toe. So that whole metatarsal is completely inflamed. What they'll do is they'll look at that and then they'll run some blood tests and they'll see that they have uric acid in their blood. So when you see hyperuricemia, they have high uric acids in the blood. If we look at these other pieces, the bacterial disease caused by the Borrelia burgdorferi, that's going to be your Lyme disease. If you look at the yellow where it says more common in weight-bearing exercises, excessive weight is a risk factor, or excess weight is a risk factor. That's your osteoarthritis. And then infection of the bone that's normally bacterial, Staphylococcus aureus, that's your osteomyelitis. So even though it's showing you this for gout, which is very important, you need to know what happens in gout, look at the other three pieces because some of that may also be on your test and they're just as equally as important. So knowing what to rule out and then what's the correct answer is going to really help you along the way. All right, true or false? Gout is a bacterial infection that's transmitted by ticks. Is that true or false? Nope, that is false. So again, that's going to be the Lyme disease that we think of. Gout is the high uric acid levels, the tick bite. And when we say a tick bite, the tick has to bite and the head has to burrow. And it usually is on a person for like 36 to 48 hours to release that bacteria, that Borrelia burgdorferi, into the system. It's very good. All right, all of the following are degenerative disc disease except what? So which one of these are issues with the bone degenerating? There's one that's not, three of them are. It's osteomyelitis. So this is a little bit of a tricky question. Three of them have issues with degenerating. Degenerative disc disease, again, we're seeing problems with that intervertebral disc, and that's degenerating. Osteoporosis, we're losing bone density because, again, we're actually stealing bone tissue. We're stealing that spongy bone or that trabecular bone. And osteoarthritis is degeneration of the actual joint. Arthritis or arth means joint. So it's trauma and damage to the joints. But osteomyelitis is not degenerative. This is an issue with an infection of the bone. The other ones are not infection. Osteomyelitis is the only one that's going to be the infection of the bone in this piece, in this circumstance. All right, osteoarthritis has a slow progression and is associated with trauma to joints. Yep, this is true. So osteoarthritis, oste means bone, arthri means joint, and itis means inflammation. So whenever you see inflammation, think redness, swelling, heat, pain, loss of function. This is damage to the joint over and over and over and over again. And there's trauma to the joint through a lifetime. This isn't one time something happens. This is a person's life of, again, were you a soccer player? Were you a weightlifter? Were you a professional football player or a professional basketball player? And that constant wear and tear on the joint is what leads to arthritis. With arthritis, we typically see that that person has problems in their joint. So they have issues with range of motion. They'll have all the inflammatory problems. They typically have stiffness in their joints, especially in the morning, but we'll also see that they have crepitus. So when we talk about crepitus, we think about that snap, crackle, pop. They start to hear that and I actually have it myself. I have it in my shoulders, I have it in my knees, and I have it in my joints or in my ankle joints. So it's always fun. All right, degenerative disc disease is associated with pain, motor weakness, and neuropathy due to compromised spinal nerves. Is this true or false? This is going to be true. So DDD, again, you have damage to that disc. It's going to basically start causing problems to the spinal nerves, and they end up with weakness and neuropathy, which is basically pain in the nerves or damage to the nerves. Very good. All right, suppuration is a stage of bone infection described as what? So when we talk about suppuration, suppuration is going to be part of the bone infection where the infection, so the bacteria, for instance, let's just say hypothetically it's staph, gets inside what's called the Haversian system. When you look at bone, and I'm going to try to draw a picture really quick. If I do this, can you see the whiteboard by any chance? Like the whiteboard that pops up?
I can see it.
Okay, sweet. So when we look at bone, bone makes those circles, and we call that the osteon. Does that sound familiar? Like the hard part of bone, the compact bone, forms
Yeah.
osteons. So this isn't spongy bone. This is compact bone. This is the hard bone. But right in the middle of the bone, and I'm going to put osteon. Right in the middle of the osteon, we're going to find what's called the central canal. And that's the central canal. So there's lots of blood running through bone. Bone is very highly vascularized. There's lots of blood vessels in bone. And these central canals are what feed the osteon. But what also ends up happening too, and I'm not going to show it from the other view, but what happens is you have these channels that connect all of these osteons together, and they call them the Haversian system. So now you got to think if you had a bacteria that got in here and now it's traveling, it's going to travel all over the system and it can affect this bone, it'll affect this part, it'll affect this part, and it just continues to spread. So that's when you hear the term suppuration. Suppuration or suppuration, depending on who says it. That's when that bacteria has now entered that Haversian canal or that Haversian system. So now there's going to be infection that takes place inside of the bone. So I hope that makes just a little bit more sense. I'm going to go back to the Kahoot really quick because then we're going to talk about what happens when there's necrotizing bone. So when do we see necrosis? All right, so now it says this stage of bone infection can lead to what? That's what called sequestrum. So when we discuss the idea of necrosis, so now this is at the end. We have a bunch of kind of buildup, if you will. There's a lack of flow. It ends up becoming necrotic. And that necrotic tissue is what we call sequestrum. How I remembered this is that necrosis and sequestrum both have an E. So then I could remember which one did what. So suppuration actually goes first, then we see sequestrum. All right. Fingers are often involved in this disease, leading to swelling-like or Bouchard's nodes. Where do we see Bouchard's nodes? This is your osteoarthritis. So when we talk about osteoarthritis, remember there's pain in the joints, there's going to be crepitus, there's a lot of times cold intolerance, but we'll also see, especially because people have very arthritic hands, we'll see that there's damage in these particular joints. And so they lead to swellings. Bouchard's nodes, you see problems in the dip joint or you can see problems in the pip joint. There's also what's called Herberton nodes. This is the proximal joint or proximal interphalangeal joint. This is the distal. So if you see problems in the pip joint or the dip joint and it leads to these deformities, we either call them Bouchard's nodes or we call them Herberton nodes. And you'll see that very indicatively of osteoarthritis. When you see these hands that kind of again start kind of shifting off like that, and they have a lot of pain and they have issues with weakness or range of motion, typically they have osteoarthritis. All right, erythema migrans, aka bullseye rash, with arthralgia may develop in a patient with Lyme disease. Is this true or false? This is true. So if you see that bullseye rash, that's likely that the person has Lyme disease. And when we see that bullseye rash, again, it doesn't always show up, but if you see it, it gives you a good indication that that person has Lyme disease. So I'm going to stop my share really quick. I'm going to show you guys what that kind of looks like. All right, so let me pop this up on the screen really quick so that way you can see what it looks like. So if you see this, it looks like a bullseye. That's the best way to describe it. And so again, this is your Lyme disease. So it doesn't always occur. And again, when we talk about Lyme disease, are you guys able to see that picture? Is that popping up?
Yes.
Cool. So you can see how it kind of looks like a target, right? Or a bullseye. Again, with Lyme disease, you have to be bit with a tick. The tick's head has to burrow into the skin, and it usually has to sit on the person for about 36 to 48 hours. And then at that point, it gives enough time for that bacteria to be released. The The bite, the tick, is actually what we call a vector. When the tick bites you and it releases that bacteria, that Borrelia burgdorferi, that's what causes the Lyme disease. So a lot of times patients don't necessarily know that they've been bit by a tick, but they may have this develop. And then again, after this develops, they usually will have like chills and they'll have a fever because it's a bacterial infection. But then later down the road, they get that arthralgia, they get the pain in the joints, they get that muscle pain or muscle weakness, and then we start thinking about Lyme disease. Again, for treatment wise, they would give antibiotics like doxycycline. But again, depending on how long this person has had that bacterial infection, it can be that prognosis may not be that they're actually healed. They may have to, go through several different events and it can affect other areas of the body. Typically, again, you're going to see arthralgia, myalgia, and again, you can see this bullseye rash. So awesome. All right. I wanted to make sure to show that to you guys. All right. Let's get back to the Kahoot. Okay, perfect. All right, this term refers to the bony growth that occurs at the edges of cartilage loss in osteoarthritis. So what do we see in patients that have had osteoarthritis? This is kind of the hallmark of osteoarthritis. Good, they get that osteophyte formation. So osteophytes is a fancy word for bone spurs. What happens is, again, you have bone here, you have bone here, and in between these two bones, we have a joint. But that joint starts to kind of diminish, and now you're starting to see that that cartilage goes away too. So now you got this rubbing back and forth of bone on bone, and what ends up happening is you end up developing those bone spurs, and those bone spurs are the osteophytes. So again, there's lots of friction here, there's rubbing of interaction on bone. We don't want that. And again, we're going to see those osteophytes develop. All right, would weight-bearing exercises be recommended for someone with osteoarthritis? So with someone that has osteoporosis, yes, we want them to use we want them to have weight-bearing exercises. Someone that has osteoarthritis already has damage to their joint. They've already put a lot of wear and tear on that joint. It's already diminished. It already has problems. The last thing you want to do is aggravate it more. So for someone that has osteoarthritis, you're going to give them exercises that allow for range of motion, but they won't give them heavy weights. So for instance, if you had a 70-year-old male that had maybe back surgery, so he had, some pretty heavy duty arthritis in his back. The last thing you want him doing is adding more weight to it and really putting more stress on that joint. So you're not going to have them deadlift. You're not going to have them do squats with dumbbells. You'll have them do things that allow for range of motion. They don't want to lose that motion in the joint, but you don't want anything that's going to aggravate it more or make the condition worse. So weight-bearing exercises are totally out for someone with osteoarthritis. For osteoporosis, it actually helps them because you then add stress to the joint or you add stress to the bone. And then again, it allows your bone density to even return a little bit. Osteoarthritis, no weight-bearing exercise. All right, so really quick, I'm going to stop my share just for a minute. So that was module 4. How do you feel with module 4 now that we went through it?
I knew more than I'd expected.
Hey, that's good. So the big things for module 4 is know the difference between osteoporosis, osteoarthritis, and degenerative disc disease. Those are the 3 big ones that you're going to have questions with. So osteoporosis, what is it? It's that porosity of the trabecular bone. It's thinning. It's because of hormones, usually lack of estrogen, no weight-bearing exercises. For treatment, because again, they're not doing weight-bearing exercises, you want them to have weight-bearing exercises. Osteoarthritis, it's that wear and tear on the joints through that lifetime. You've already stressed out that joint. You don't want to add more to it. So there's no weight-bearing exercises for them. And again, they already have those bone spurs because of those osteophytes that we're going to see. For degenerative disc disease, again, it's either in the neck or it's in the back. You're usually going to see neuropathy to go along with it. Those discs are impinging on those spinal nerves. They have lots of neuropathy issues. And when you think neuropathy, think pain in the nerves. So again, tingling, numbness, pain, even a burning feeling. That's what you're going to typically see. All right, other things to make mention of that are in Module 4. Know what Lyme disease is. So what causes Lyme disease? What are the signs and symptoms? It's because of that tick bite. It releases that bacterial infection. We're going to see that bullseye rash, that erythema migrans. We'll typically see arthralgia, myalgia, fever, fatigue. Know what gout is. Gout's that high uric acid levels in the blood. Typically, again, we see it more in males, especially alcoholic males. And again, we're going to see that big red toe. The other thing to make mention of is to know the definition of rheumatology and to know sequestrum suppuration. So those levels of bone healing. That is going to be the majority of that. Because remember, it's 75 points, but now we have module 4, 5, 6, 7 to cover with. So it's usually about 20 to 25 questions each. Module 4 is probably about 18 to 20 questions by the time it's all said and done. All right, let's go into module 5 because I know module 5 was really hard for a lot of students because that's the digestive system. So let me go ahead and I'm going to open this up. And you can go ahead and jump into this Kahoot. Okay. All right, let's go ahead and get started. So this is module 5. This is digestive system. All right, so which inflammatory bowel disease produces skip lesions? All right, so when we discuss inflammatory bowel diseases, typically we're thinking of ulcerative colitis and we're thinking of Crohn's disease. Crohn's disease has skip lesions, which means that it has areas of healthy colon, and then their next part will be all messed up. And when we look at it, actually, it appears like a cobblestone kind of look. We also say that Crohn's disease is transmural, so it goes through that entire organ tissue, but it looks very cobblestone. But that will continue for a little bit, and then the next part will be healthy again. And then there'll be another section that's unhealthy or has that cobblestone look. So when they say skip lesion, it's an area of disease followed by an area of healthy. A little part of disease followed by an area of healthy. And that's running through the colon. Which term refers to blood in the stool? Good. So when we're talking about blood in the stool, when you hear the term melena, there's lots of blood in the stool. And usually melena is also going to be black. So you'll see like almost a black tarry stool. This is someone that has a GI bleed. So again, especially when we talk about like peptic ulcer disease, when we think of chronic gastritis, any of those any of those problems where we're starting to eat away at different tissues, a lot of times you'll see bleeding because of that. Because we're getting down to those layers where like the submucosal is now appearing, and that's where all the blood vessels are. So now that's getting hit. There's lots of bleeding, and that blood has to go somewhere, so it goes into the stool. And typically it shows like a black color. All right, which organ has endocrine and exocrine function? Good, it's the pancreas. So the pancreas, when we talk about the digestive system, has exocrine function. It releases enzymes into that common bile duct. When we talk about endocrine, that's when we think about insulin and glucagon. And that's when we think about like diabetes mellitus potentially. All right, what term refers to difficulty swallowing? Difficulty, painful. Good. Dysphagia. So when we talk about dysphagia, this is just that problem with swallowing. And it's so funny because I think I mentioned this in class, but I got reiterated today when I was in the LRC. A student that's in semester 5 said, "You were absolutely right. They asked me to know all the cranial nerves for swallowing." So go back into your notes and memorize those cranial nerves. It's not on your final for this class, but it's going to come right up in semester 5. When we think about our cranial nerves, you have cranial nerves that allow for your tongue movement, the hypoglossal nerve. So one of the things that you'll do is you'll ask your patient to stick their tongue out. If they can't stick their tongue out and they can't move their tongue very well, typically they have a cranial nerve issue. They're going to have problems with swallowing. The other thing too is you want to actually watch them, which is called the glossopharyngeal nerve. You want to watch them swallow. So you're going to say, okay, take a big swallow. You're watching them swallow. If they're having any difficulty or it's painful or something's not looking right, you're going to be kind of worried for that. And again, chances are you're not going to have them eat whole foods. They'll usually do a liquid or, maybe they have to do a tube. So this will come back up, I promise you. So just memorize those cranial nerves now, not because it's on your exam, because it will help you out in the long run. All right, which of the following describes occult blood? Good. This is microscopic blood. Typically, when you hear the term occult blood, you don't see it with the naked eye. So they will look at it underneath the microscope. And again, when they do a blood culture, they're usually looking for bacteria and things like that. They also might see in that blood culture that there was a little bit of blood. They'll see red blood cells, which should not be found in your stool. That's kind of a little bit weird to see, and that's what they would be looking for. Versus the dark tarry stool, that's your melena, and the fat stool is that steatorrhea. All right, which of the following causes dysphagia due to motility issues? There's a problem in the esophagus, and they can't move the food down. What would that be called? That's going to be called achalasia. Now, it can be due to a stricture, but when we hear the actual term, it's an achalasia. Achalasia is that esophageal motility issue. All right, which organ absorbs vitamins, nutrients, meds, and is involved in the immune system? Big, heavy part absorbs. Which one does the majority of absorption? Good. So that's the small intestine. So this is kind of a big thing to keep in mind is most of our stuff is going to drain into the duodenum And the duodenum allows us to finish up digestion. And then the rest of the small intestine takes that time to absorb nutrients. They have those little villi that help with that absorption. If you have problems with your common bile duct and those enzymes don't get into the duodenum, so again, maybe there's a problem with the pancreas, maybe there's a problem with the gallbladder, maybe there's a problem with the liver. If they're not getting those enzymes into the duodenum, they're not having good chemical digestion. And if they're not breaking things down, they're not going to be able to absorb. So just something to keep in mind. All right, what is caused by incomplete lower esophageal sphincter or an I'm sorry, not incomplete, incompetent lower esophageal sphincter? Good, that's your GERD. There's a problem with that lower esophageal sphincter. It's not closing correctly. It's maybe weak. And then now that gastric juice is going back up into the esophagus. Very good.
Fast.
I'm sorry.
What too fast?
Okay. Yeah, way too fast. All right. Manual pressure can be used to put this hernia back into normal position. All right. So when we talk about hernias, there's a couple hernias you're going to have to know for your test. You're going to first have to know what a hiatal hernia is. Hiatal hernia has nothing to do with your colon or the small intestine, large intestines. It has to do with the stomach pushing up into the diaphragm. That's your hiatal hernia, number one. The other hernias that we speak of are thinking about your intestine. So either they're looped around something that they shouldn't, they're cutting off blood supply, or they're just in a funky area where they're now shifted. With the reducible hernia, you can push it back into normal position. Now, we cannot do it. There are doctors and specific people that can use manual pressure to get it back into place. If you have a strangulation hernia, you're cutting off blood supply. This is very serious. And then if you have an incarcerated hernia, what's happening is the loop of intestines gets stuck between muscle fibers. And so when you hear the term incarcerated, think about like someone in prison. You're imprisoning that intestine around the muscle. So therefore, you're going to have some issues, and that leads to that hernia. All right, which medical term means intestines, as in small and large intestines? Good, that's your enero. Good. Versus the stomach would be what? What's the medical term for the stomach? Good, gastro. So when you hear gastritis, like acute gastritis, chronic gastritis, we think inflammation of the stomach or inflammation of the stomach lining. If you hear the term enero, we're thinking intestines. So gastroenteritis is inflammation of the stomach and the intestine, typically because of infection, like a 24-hour stomach bug or some bacterial infection. So stomach is gastro, enero is your intestine. All right, celiac disease causes damage to the small intestine, causing malabsorption. The loss of fat in stool is known as what? Good steatorrhea. So, how we talked about the intestine is really important for absorption. Celiac disease actually damages those little villi. So, because of that gluten intolerance, you make antibodies, and those antibodies attack those villi. So, therefore, you don't have good surface area. You don't absorb anything. So, not only do they have diarrhea and they have bloating, gas, things like that, and then obviously fat in their stool, they have a big problem with absorption. All right, all of the following are helpful in diagnosing H. pylori, but one. So three of them are right, one of them is wrong. Which one's wrong? Good, the CBC. So H. pylori or Helicobacter pylori is a bacterial infection. So this bacterial infection is typically found in the stomach. It can also be found kind of in the duodenal area too. So because of that, because it's a bacteria, we can do a stool test and actually look for the antigen itself, look for the H. pylori. You will also make antibodies against it because it's a bacterial infection. So your body makes antibodies. So they can do antibody testing to see if you have the antigen in your body present and if you made antibodies. The other thing too that's weird about H. pylori is it gives off something called urea. So we can do what's called a urease breath test and confirm H. pylori. The CBC is really not going to be helpful unless you're looking at particularly white blood cell count. The other three are going to be way more helpful to actually diagnose that it is H. pylori. All right, in peptic ulcer disease, what is broken down that causes the ulcers to occur? Good is that mucosal layer. So when we think about your stomach lining, your intestinal lining, you have a submucosa and you have a mucosal layer. That mucosal layer is internal. And again, it's full of goblet cells that produce mucus. Mucus is there to protect your body, protect your tissues against super acidic natures. Like your stomach is really, really acidic. If you don't have that mucosal layer, then you get to submucosa. Submucosa is where you find nerves and where you find blood vessels. So with peptic ulcer disease, a lot of times people talk about intense gnawing pain because now you're hitting blood vessels. A lot of times too, they will have bleeding as well. And it's because again, you've shaved off that mucosal barrier. There's no mucosa. You're now down to submucosa. There's a lot of pain and there's a lot of times bleeding. Good. All right, this type of hernia presents with GERD, belching, and possibly dysphagia. So think about that. Yeah, very good. That's a hiatal hernia. So typically they have epigastric pain because it's kind of from their stomach. And a lot of times they have very similar like acid reflux issues. So the big thing is that they'll give them drugs for the acid reflux, like a proton pump inhibitor. Maybe they will give something for just balancing that acidity. But if it's really bad, then they will do surgery. Excuse me just for one moment. I'll be right back. All right, next question. All right, a patient has just had a cholecystectomy, so the removal of their gallbladder. Which macronutrient are they going to have a problem digesting? They're going to have a problem with fats. Very good. So, for this person, would you suggest a very high fat diet or would you tell them to restrict their fat intake?
Restricted.
You're restricting it. So yeah, this person's going to eat very lean meats. This person's going to eat like steamed vegetables. There's no Chick-fil-A, there's no, Burger King, no KFC, nothing high fat, high grease. That's going to give them lots of trouble, especially in the beginning. As time goes on, they may start being able to process those foods, but up front, nope. It's going to be very much restrict as much fat and grease as possible. All right, what is commonly found in the stomach that contributes to peptic ulcers?
H. Flores.
Yeah, good.
Flores.
Yep,
My
H.
Kahoot is
pylori.
messing up, so I'm sorry.
You're good. You're good. If you want to throw in the chat too, whatever's easier for you. But yeah, H. pylori is what's found in the peptic ulcers for sure. So again, you'll see it with acute gastritis. We see it with chronic gastritis, and you'll see it with peptic ulcers. Not, it doesn't always cause those problems, but it is one of the culprits. So again, other things that can happen are stress, alcoholism, things like that. But H. pylori is commonly found and helps to contribute to ulcers and gastritis. Good job, guys. All right, which of the following is not a complication of peptic ulcers? So again, write in the chat, shout it out loud, whatever you guys got to do.
Diarrhea.
All right, very good. Diarrhea. So, one complication you will definitely see with peptic ulcers is perforation. What that means is that that ulcer was so big and that bleeding was so big that now you basically like have a hole in the intestine or in the stomach, wherever it may be. And now that person's hemorrhaging. Very common to happen with ulcers. Again, you sort of have like this gaping hole because of that ulcer. It goes deep enough that it perforates through. You also can lead to obstruction because now again that whole spot is ulcered. So there's not going to be good movement going through that area. And again, hemorrhaging goes with that perforation. Typically, you don't see diarrhea. You're going to see more likely constipation take place. All right, a patient has been diagnosed with choledocholithosis. What do they have?
Stones in the common bowel duct.
Good, it's the common bile duct. So if you're seeing problems with the gallbladder, you're going to see cholecyst. Cholecyst is gallbladder. Common bile duct is choledocho. Lith means stones. And so we just want to be careful with some of those terminologies. But choledocholithosis, common bile duct, you got stones in the common bile duct. All right, what is not able to be metabolized with someone that has celiac disease?
Gluten.
Good. It's going to be gluten. And so a person that has celiac disease, they do not metabolize gluten. Sometimes people will say that they have a gluten hypersensitivity or insensitivity to gluten. It's autoimmune typically, and your body actually attacks the gluten. It thinks it's something foreign and terrible, and so it attacks the gluten. That leads to the malabsorption because, again, it breaks down those villi in the small intestine. And then they also get that steatorrhea. They get that fat in their stool. All right, what condition is caused by cirrhosis? So you have liver cirrhosis and it leads to this particular thing.
Get
So
that.
there's two of them that go along with it. We see problems with the hepatic encephalopathy, and then we see that esophageal varices. So these come after cirrhosis. You have cirrhosis of your liver, they're going to lead to esophageal varices and hepatic encephalopathy. All right, this type of hepatitis is bloodborne and has a vaccine. That's Hep
Hepatitis.
B. Yep, very good. Hepatitis B. If it is bloodborne, but there's no vaccine, that's your Hep C. So you won't be asked very many questions. In fact, there's only one question. It's either going to be B or C. So it's bloodborne, and they want you to know which one has a vaccine and which one does not have a vaccine. All right, this type of hepatitis is transmitted via fecal oral route.
It's A&E.
Yeah, you're going to see it for A and E. So A and E both are oral fecal. B and C are bloodborne. Very good. Last question. Ulcerative colitis starts in the rectum and spreads to where?
Large intestines.
Large intestine. Very good. All right, so I know that module 5 feels pretty rough because there's just so much going on. So there's a lot. There's a lot to know in Module 5. Module 5 is all of the digestive system dysfunctions or the digestive system issues. So there's problems in the stomach. We're talking about problems in the intestine. We're talking about problems like, again, especially thinking about the colon. So I wanted to just take a moment and kind of tell you guys a little bit more detail as to what to expect in this particular area. So for your final, you definitely want to know the difference between ulcerative colitis and Crohn's disease. Which one has skip lesions? Which one has the cobblestone look? Where are you finding Crohn's disease? Where are you finding ulcerative colitis? That's going to be very, very helpful. A couple other things too as well. Make sure you know what celiac disease is. So the gluten intolerance. And again, know about that statorrhea. That will be very, very helpful. We talked a lot about poop. So when we talked about poop, we talked about melena, we talked about statorrhea. Definitely know those. Which one is the black tarry stool? Which one of them is the fat in the stool? You want to make sure you know gastritis and peptic ulcer disease. Now, when we're talking about peptic ulcer disease and we're talking about gastritis, the signs and symptoms are very similar. So, a lot of times you're going to see that that person has an history of NSAID abuse, maybe they have alcohol abuse, but that's okay. Know those signs and symptoms and know, again, like, are they having pain? Are they having any blood in their stool? Are they puking up any blood? Do they have pale skin? You're going to want to know a couple things there. So that no gastritis and peptic ulcer disease. Like I said, you either have to know Hep B or Hep C. They're going to want to know which one's transmitted via blood products, which one's got the vaccine, which one doesn't have the vaccine. That'll be a big one. Um, we talked about, and they weren't unfortunately in this Kahoot, but we did make mention of the idea of like pancreatitis as well. So, what is like a Cullen's test when someone has an acute pancreatitis? Know that a Cullen sign is found with acute pancreatitis. What are the signs and symptoms of someone that has acute pancreatitis? Also, with cholecystitis, so someone that has a gallbladder issue, uh, what is a Murphy sign? So typically what's going to happen is when the examiner palpates under their ribs, a lot of times they're going to stop breathing, and a lot of times they'll talk about having really bad tenderness. So they're kind of feeling around, and when they start to push underneath their rib, they stop breathing or they go and they have like a lot of pain, and sometimes they'll even have guarding as well. So that's really, really helpful. So definitely want to know those pieces. What's a Murphy sign? What's a Cullen sign? What are some signs and symptoms of gastritis? What are some signs and symptoms of pancreatitis? Let me go through a couple more things as well to make mention of. Um, let's see. Those are the big ones I wanted to make mention of. What is achalasia? So again, what are we seeing there? How do you diagnose H. pylori? What is a hiatal hernia? What are the different types of hernias like strangulation hernia, reducible hernia? Uh, what is diverticulitis? So basically, what is it? It's that inflammation of the diverticula, and it leads to this obstruction. Again, what is choledocholithiasis? You know, those stones in the gall, a common bile duct. So yeah, those are some big ones that you'll want to make sure to know. So I also am recording this. So if you have no idea what I just said and I talked really fast, don't worry, you can go back and replay this. I'll make sure that's posted to your guys' announcements. How are you feeling so far? Is this okay? Any questions, concerns, anything going through? I know there's a lot been thrown at you.
It's actually way better than what I thought it was going to be. You do a really good job.
Okay, thank you. I appreciate it. So that's just 4 and 5. We still got 6 and 7. 6 is going to be, unless you guys, again, if you have to stop at any point, that's fine too. But I'll just kind of keep running through it. For module 6, we need to know endocrine and we have to know nervous system. And then finally for chapter module 7, that's the urinary system and that's the reproductive system that we're going to see problems with. So the next one is module 6. It's going to be split between like what are strokes, what is Parkinson's, so what is multiple sclerosis, and then we get this whole other part of the endocrine system that we're going to see. So diabetes insipidus, diabetes mellitus, Cushing's, all that good stuff. So let me go ahead and pull this up really quick so we can play this Kahoot. All right, and I'm going to pull this up really quick. All right, so again, module 6 will be endocrine system, and then we're going to think about nervous system. All right, a woman presents with striae, moon face, hirsutism, a buffalo hump. What disease does she most likely have? So it won't be hypothyroidism. This one's going to be Cushing's disease. So when we go to remembering these, with thyroid, you either have Graves' disease or we have Hashimoto's. With Graves' disease, they tend to have like the bulging eyes and they have like all of the things of like an over metabolism going on. So they're usually hot, they have high energy. A lot of times they'll have issues like staying straight in one place. They have a lot of insomnia. They have issues with their calcium levels. Hypothyroidism, typically we'll see that they have weight gain, but they won't have the moon face and buffalo hump. They will have weight gain. Usually they have brittle hair and nails. A lot of times they'll talk about feeling sluggish or lethargic, and even though they're not eating, they're still gaining weight. Now, with the adrenal glands, which is the adrenal cortex, our issues are Addison's disease and our issues are Cushing's disease. Addison's disease, we see that they have underactive cortex hormones. So they're usually pretty thin. A lot of times we see electrolyte issues, so problems with calcium and problems with sodium, problems with potassium. They also can have an absence of a period because that cortex also makes the sex hormones. So if those sex hormones are underactive, then they don't have a period. And then they get the funny pigment in their teeth. With Cushing's disease, the big ones are that they get this moon face, and they call it a moon face. They call it a buffalo hump where they get this fat deposit on their neck. And a lot of times you'll see that women develop facial hair, which is the hirsutism. So keeping all of those straight is quite fun, but definitely no signs and symptoms. All right, which hormone is deficient in diabetes insipidus? This one is going to be antidiuretic hormone. So when you hear diabetes insipidus and diabetes mellitus, they are two different things. Diabetes insipidus is an issue in the pituitary gland in which they don't make enough ADH. Diabetes mellitus is a problem with insulin levels because of the pancreas. But when you think of antidiuretic hormone, that's an issue with diabetes insipidus. They don't make enough antidiuretic hormone, so they actually pee a lot, and then because they're peeing so much, they're actually drinking a lot. We call it polydipsia and polyphagia. All right, diabetes insipidus and diabetes mellitus share this clinical manifestation. There's actually two of them, but one of them's on here. Good, it's going to be polyuria. So when we talk about diabetes insipidus, they have two P's, polydipsia and polyuria. They drink a lot and they pee a lot. For someone that has diabetes mellitus, they're going to have issues with the three P's, polydipsia, polyuria, and polyphagia. They eat a lot, they drink a lot, they pee a lot. This has to do with insulin not actually getting into the cells. The insulin's supposed to drive glucose into the cell. Because they're not able to do that, the cell feels like it's starving and it's actually losing water. Like I said, diabetes insipidus and diabetes mellitus have nothing to do with each other. One's about the pancreas, one's about the pituitary gland. One, you don't make enough antidiuretic hormone. One, you don't make insulin. So just make sure you know that they're two very different diseases. Besides having the term diabetes, that's about the only thing they have in common. And again, those two P's, polydipsia and polyuria. All right, a patient reports a 12-pound weight gain in 1 week. They have dark urine, they have very low sodium levels, They have tachycardia, which is high heart rate, and an elevated blood pressure. This one won't be hypothyroidism. This one's going to be a problem with something called SIADH. The hints for this one is that they gained a lot of weight very, very quickly. Typically, it's water weight. The other thing is they have very, very dark urine. So when we talked about diabetes insipidus, they don't make enough antidiuretic hormone, so they constantly are peeing. SIADH is syndrome of inappropriate antidiuretic hormone. And for this one, they way over make antidiuretic hormone. Antidiuretic means that you're not peeing, you're conserving water, you're conserving sodium. So with this guy here, they're sucking all the water in. So that's why they have such a heavy weight gain so quickly, because it's mostly water weight. And the dark urine is the hint. But also, we're seeing problems that because, again, they have such high water content, they're going to have a very high blood pressure. They're going to have a high heart rate. And they have sodium problems too, because now they've retained all this water. So, keeping them all straight is going to be the hardest part. My suggestion would be to make like a colored chart of, okay, what are the two diseases I see for antidiuretic? What are the two diseases that I see for thyroid? What are the two diseases I see for adrenal cortex? And kind of then fill that in. It will help tremendously, I promise. All right, uncontrolled gestational diabetes results in what? All right, so when we talk about uncontrolled diabetes, and this is what we call gestational diabetes. So what happens is when mom is pregnant, she ends up developing this diabetes. Usually by second trimester, they can diagnose it. What's going to happen here is you're typically going to see that the babies are born premature and they're usually very big babies. So even if they're born at 37 weeks, 38 weeks, they're still like 9, 10-pound babies. They're big babies. They call it macrosomia. Then we are going to see that they have hypoglycemia. So even though mom has all this sugar, she's hyperglycemic, baby's actually the opposite. Baby is hypoglycemic. And usually they have a premature delivery. So they're born early. They're not born on at term or after term. They're born like 36, 37 weeks, maybe even 38 weeks. But they're usually born before the due date. And again, it's just because they're so big, usually the doctor will take them early. All right, a patient presents with polyphagia, polydipsia, polyuria, weight gain, and works at a computer all day. What do they have? Yeah, that's your type 2 diabetes mellitus. So the three P's, if you see obesity or sedentary lifestyle, that's going to be your diabetes. Type 2. A patient represents with right-sided weakness, facial droop, and a CT scan reveals they have a hematoma. What's going on here? Now we're getting to nervous system. This is the hemorrhagic stroke. Very good. So when we talk about strokes, most of them are ischemic. So again, there's an issue with lack of blood flow. So maybe there's a clot in one of the arteries. Maybe they have stenosis or they have sclerosis. There's hardening, there's narrowing, there's plaque, something leading to lack of blood flow. On the flip side, we also have hemorrhagic. Hemorrhagic's like a rupture, so it's like an aneurysm. And if you hear the term hematoma, now you got a lot of blood pooling in that area. So that's very common with a hemorrhagic stroke. All right, which is the best definition for ischemic pneumbra? All right, so with this one, what we're seeing is when someone has that ischemic stroke. So ischemia is that lack of blood flow. So that one particular area of the brain didn't get oxygen. Because it didn't get oxygen, it led to an infarct, just like what we've seen with the heart in heart attacks and myocardial infarctions. So there's an area that's completely damaged, but around it is a perimeter of just very heavily inflamed area, and it is agitated, but it hasn't died off yet. So this part is still salvageable if someone can get medical attention right away. If they don't get medical attention, now that infarct is going to spread. But if they can get to it quickly and they can get oxygen to this area, then they can actually save that tissue. So the core is the damage or the infarct. The area around it is called an ischemic nubra. Which component is not part of Cushing's triad? Cushing's triad, it has to do with intracranial pressure. So when someone has a hemorrhage. So that is not part of it. Left-sided weakness is not part. With Cushing's triad, you see three things. You see problems with heart rate, you see problems with breathing, you see problems with blood pressure. Because there's so much blood pooled into this area, and remember, you have a brain and it's coated or it's covered with a skull, with a brain case. If you now have all this blood in the brain case, you lead to what's called intracranial pressure. So the area between the brain and the skull, that's all full of pressure now. And so because of that, it leads to what's called hypertension or really high blood pressure. But you'll see that also because it's causing damage and it's actually hitting part of the medulla oblongata, that we'll see that the person starts having changes to their breathing and to their heart rate. So they typically have what's called bradycardia and bradypnea. So they have a very slow heart rate and they tend to have slow breathing, but they have hypertension. All right, patient has excruciating unilateral headache, bloodshot eyes, and nasal discharge. What kind of headache is this? This one is called TAC. This is one just to memorize. I don't have very many questions about a headache. This is the only one. It's trigeminal autonomic cephalgia, very common in males. They get one side of pain just right here, and they talk about it being excruciating, like this, like thumping pressure. A lot of times you'll see that they have what are called bloodshot eyes, and most of the time they have a very hard time sitting still. So this is very common in males. Again, one-sided pain, bloodshot eyes, a lot of times their nose will run and they do not sit very well. Like they can't sit still, they can't stand up. They're just very, very almost agitated, if you will, because of it. All right, this disease is characterized by progressive loss of dopamine from the substantia nigra. Yeah, this is going to be Parkinson's disease. So Parkinson's disease is a lack of dopamine. When you have a lack of dopamine, dopamine does excitatory effects. It's a neurotransmitter. It has excitatory effects. It has inhibitory effects. So unfortunately, when you have a lack of dopamine, when you shouldn't see things, you're seeing them because now they're excitatory. And when we should be seeing things, but we don't, now they're being inhibited. So a lot of times you're going to see tremors. A lot of times you're going to see problems with coordination. A lot of times it's planning too. So like things are not on autopilot. They have to think about every movement that they're making. And a lot of times we'll see what's called bradykinesia. They have a really hard time with moving. Eventually it leads to akinesia where they're not able to walk very well or move around very well. They make very small movements. A lot of times you'll see their feet shuffle. They don't have good posture, and a lot of times they have gait weakness, so they don't have good balance. All right, damage to the cerebrum would make this clinical manifestation. It's going to lead to ataxia. So when we talk about the cerebellum, we're thinking about issues with movement and coordination, balance, posture, coordination. That leads to ataxia. All right, this type of mini stroke is caused by a temporary decrease in blood flow. Good. This is the TIA, transient ischemic attack. Very good. All right, the largest risk factor for a hemorrhagic stroke. So who's the most at risk? This one's going to be hypertension. Uncontrolled hypertension, uncontrolled very high blood pressure can lead to a rupture. Same thing with an aneurysm. So aneurysm, uncontrolled blood pressure, definitely make you more at risk for a hemorrhagic stroke. All right, last question. The attack and lack of myelin sheath causes this disease. This is MS. So Parkinson's disease is the lack of dopamine. Multiple sclerosis, you have T cells that attack that myelin sheath. And so that, because that happens, it leads to like a lot of lesions on your brain. And so the person typically has issues with weakness. A lot of times they'll have problems with speech and coordination because it all depends on where the lesion's at. All right. So how do you feel with module 6? Does that feel a little bit better?
No, it feels terrible.
Okay, so definitely go through module 6. Module 6, so that Kahoot, I think I posted. In case I didn't, I'm gonna post it right now. This one is very, very helpful. All right. I'm posting it right now, so that way I have it in the announcements. Kahoots for module 6. And I'm going to put one in for module 7 too. So that way there's some for 6 and there's some for 7. Okay. Hmm. Let me do one more. Okay, I just posted, well, I haven't yet. I'm posting some Kahoots now for module 6 and module 7 as well. So they're on one announcement. I just got to post them to the other announcement real quick. All right, so those are posted. So make sure to go ahead and play those. They're going to be very similar to what you're seeing for your exam. All right, so really quick, let's go ahead and play one more Kahoot. We're going to do module 7, and then we will be done for the night. So module 7 is just what we went over, yesterday or last Wednesday, because today is Friday. My brain's all messed up because of the holiday. But this will be the last one that we'll do. All right, decreased urination, such as holding your bladder, can cause bladder infections. Why are women at high risk? All right, so for females, the big issue for bladder infections is because we have very short urethras and they're very close to the anus. So that makes a big problem.
It's confused me because it said holding your bladder, not when you like, I'm thinking about,
Well, so that's the thing is if you are constantly holding it, it does make you more likely. Same thing like so for females, the big issue is wearing really tight clothing and sexual intercourse.
Right.
So, like, thongs are really bad, tight jeans are really bad, like all the things that, we like to wear. They're all really bad. Leggings are really terrible actually because of those, because they're so tight on the body. But then same thing, like because we typically don't drink enough, like not drink enough water, and then the constant not using the bathroom. So all of those things can lead to it. But the big problem is the urethra is so close to the anus. So that's a big problem that we'll see.
Um,
That bacteria just kind of holds in there. All
right.
right, the ureter has become blocked, and there is a backup of urine toward the kidneys. What term best describes this event? So now you got all this water in the kidneys or urine in the kidneys. So this is called uropathy. So uropathy or uropathy is going to be problems with obstruction, and a lot of times, again, it's going back into the ureter or it's going back into the kidney, depending on the location. Urine outflow has been blocked and the renal pelvis is starting to dilate. If you have problems in the renal pelvis, so water's going back up into that, what do we call it? This one is called hydronephrosis. So when you hear of fluid in the urine or in the renal pelvis, which is like kind of like that funnel shape, or if you hear about like any sort of water going back towards the kidney, we're thinking of hydronephrosis. If there is urine stuck in the ureter or there's obstruction in the ureter where there's now accumulation, we call it hydroureter. Typically, they're because of a stone. We get that backflow happening. All right, this disease is most common a cause of urine obstruction in males over the age of 50. So this is really common in old men. Like 80% of them are over the age of 80. BPH, very good. All right, this term refers to surgical removal of a testicle because of cancer. So what is it called when we take one of those testicles? Good, it's orchectomy. Good. All right, true or false? Secondary sex characteristics normally appear in females between 8 and 13. Good, that's true. All symptoms of glomerulonephritis except one. So glomerulonephritis, all of them are correct, but one of them. So they will have swelling for sure. They will have dark urine because they're really not peeing. And because they're not peeing, they're retaining all this water. So we call it hypervolemia. They have a high volume, but they're not going through polyuria because polyuria would mean that they're peeing a lot. They're really not peeing. So it's called algouria, which means like scanty urine or very little urine. All right, pyelonephritis refers to an infection of which part of the kidney? It's going to be the pelvis, the renal pelvis. So pylopelvis. Pylopelvis. And this is an infection that we're going to see, usually a bacterial infection. All right, mumps increases the risk for which disease or condition? So for boys, this is really common that they get this post a mumps infection. This one's called orchitis. So orchitis is inflammation of the testicles. And like I said, super common post a mumps infection for boys. All right, this type of incontinence is caused by a stroke. This is called functional incontinence. So functional incontinence is for a stroke victim. Stress incontinence is for those moms with pelvic floor issues, typically women, mostly moms. This type of incontinence occurs with events like jumping, squatting, coughing, sneezing. Good, that's that stress incontinence. All right, this condition is characterized by protein in the urine. This is called nephrotic syndrome. So this is where they have such bad kidney damage, it's led to nephrotic syndrome. And eventually, if it doesn't resolve, it will end in end-stage renal failure or end-stage renal disease. All right, endometritis is the displacement of endometrial tissue. Is this true or false? Endometritis. Itis is the part that we look at. It's false. Endometriosis is the displacement of tissue. Endometritis is actually an STD, which is defined incorrectly. So three of them are right, one's wrong. So it's going to be metrorrhagia. Dysmenorrhea is those painful periods, excessively painful periods, typically in younger girls. Amenorrhea, they don't have a period. Menorrhagia, they're bleeding for more than 7 days. But metrorrhagia is when you have multiple periods. Glomerulonephritis can occur in the following of which infection, or occur following which infection? Strep, good. Which is most likely the cause of pre-renal failure? So why are they having problems before in that renal artery? It's hypovolemia. Hypovolemia. So they don't have good blood flow. All right, 2 more questions. All right, CVA tenderness and flank pain are indicative of what? So when are you going to see that they're having pain? They have some abdominal pain as well. Think about in the back. Yep, kidney issues. All right, should a high protein diet be recommended for someone with chronic renal failure? No, you don't want to have them. So they should not be on a high protein diet. It actually can worsen it. And especially like that's not saying that they can't eat protein. They have to eat very lean protein. So it's not avoid protein at all costs. It's You can have some lean protein, but excessive protein, it will make it worse. All right, renal calculi are caused by insufficient calcium from diet. It's going to be false. So they make too much calcium. They make too much. It's not that they don't make enough, they're making overproductions of calcium. And that's what's leading to kidney stones. All right, so that was the last Kahoot. So woohoo, you survived all of this Kahoots. I know that was a lot, but I hope that that totally made sense and kind of brought everything together. And at least if you were getting things right, you kind of know where to study. So I hope that helped just a little bit. All right, well, I'm going to let you guys go. I actually am doing another review for Bio 189 tonight. So your guys' was from 6 to 7. I got one from 7 to 9 tonight. So I'm going to go eat really quick before we have the review. But I hope you guys have a wonderful night.
Thank you.
Thank you. Bye.
Bye.